Good evening again. I'm Dr. Nandakishore. I'm a pediatric intensivist at the KIMS Hospital, Hyderabad. This evening, I'm going to discuss about nursing care and adjunct therapies for the patients on ECMO. So there's nothing to disclose from my side. So we're going to talk a little bit about general nursing care and a little bit about monitoring, nutritional care, and is physical therapy possible and how to do it if it is feasible. And then also a little bit about managing a patient or awake patient on ECMO. So nursing care starts as soon as we get called. It's not for the nurses, but it's for the patient to care provider. It doesn't matter who provides it. And this should start as soon as we get a call for possible ECMO. It starts with the pre-ECMO checklist. If one could have a checklist like this to go through it would be better so that we will not miss out anything. And what we need is how sick is the patient, what kind of support he or she needing, and what is the patient weight, and any comorbidities. And then identify where we're going to keep the patient, or does it need any specific isolation facilities. And then arrange the appropriate circuit, cannulas, and all the equipment necessary for to initiating ECMO. And prepare the part, reserve blood in case if you're going to do a blood priming, and highlight any coagulation abnormalities which can change the anticoagulation strategies. And then take the consent from the family. And then when the patient goes on ECMO, some monitoring is like any other critically ill patient. So we documented vitals along with neuro observations at regular intervals. Make sure that it's take strict aseptic precautions so that will prevent hospital-acquired infections. And the prevention of bed sores is one of the most important things because many of these patients are sedated and paralyzed, and they're in ICU for sometimes weeks together. So we need to take all measures to prevent bed sores. And where possible, try to do sedation holidays. When the patient is stable on ECMO, where we can give sedation holidays, that would be better. And avoid all unnecessary invasive procedures. It doesn't mean that if we need to do something, we can do it. The reason being that anticoagulator and the risk of bleeding is there. But if needed, we can do the procedure, but we need to justify why we need it. I mean, in some patients, we even did surgeries when it is necessary, but we need to really justify why we need it. And it has to be done by an experienced person. And then about the circuit monitoring, one needs to be aware of how the circuit functions and how to troubleshoot it. And document all the parameters from the circuit side, that is revolutions per minute, how much flow, and what is the pressure difference across the oxygenator, what are the ACT levels, and how much the heparin dose is being given, and the cannula, etc. So for again, if you have a checklist kind of thing each shift, that would help to not to miss out anything. A little bit about RPM versus flow. So if we need to increase the flow, we need to increase the revolutions per minute, but that is not always the case, as we discussed in the previous talk. Similarly, flow versus sweep gas, we usually aim for 1:1. Sometimes, depending on the blood gas exchange, we need to go up and down. So one important aspect is there's a water condensation happens over the membrane over a period of time. So we need to increase the sweep gas to, say, from 10 to 15 liters for a short period of a few seconds. You just flush out that water from the membrane oxygenator, so that the oxygenator function doesn't get hampered. So this is a kind of sheet what we use at our hospital, which kind of takes all the patient details and what side of cannula we used it, and what kind of ECMO circuit we used it, and then take all the patient related and pump related parameters on the sheet. And this is the kind of ECMO checklist what we use. We go through the safety checklist for ECMO and the bedside inspection checklist as well. So these kind of things would always help want to go through each and every aspect of the ECMO care. So coming to nutritional care, patients on ECMO are at high risk of malnutrition because of the increased catabolic state. So the very high risk of malnutrition. So in those patients, consider enteral feeds as soon as possible, provided there's no contraindication. Generally, gastric residual volumes is taken into consideration, but that should not be used routinely to for the advancing the gastric feeds. If you too much of gastric residual volumes, consider prokinetics or a post-pyloric feeds. Again, depending on the requirement, either you can go for a bolus feeds or continuous feeds. Usually, we tend to start with bolus feeds as soon as possible. If there's intolerance, then either we try continuous feeds or post-pyloric feeds. And it's always better to have a protocol based for the unit so that there won't be any delays in starting nutrition. Because as you look at the feeding is one of the least important measure in ICU, and one of the most major reason for malnutrition ICU is avoidable these things. Like either you don't start into nutrition soon, or you delay it from some procedure or intermittent delays. So we need to have some kind of a protocol so that we can minimize those delays, and wherever we can give enteral nutrition, give enteral nutrition. But in situations where enteral nutrition is not possible, we can consider parenteral nutrition. But it's better to avoid it during the first week of illness. It's been shown that if you start parenteral nutrition within the first week of illness, there's increased risk of morbidity and mortality. But it only applies who are at nutritionally low risk. Somebody has a high risk of malnutrition, and they can be started parenteral nutrition as soon as possible. So usually you would expect a patient to go on to enteral nutrition by end of week. If not gone end of 1 week on enteral nutrition, then you can consider parenteral nutrition. And parenteral nutrition can also be added to the enteral nutrition, where enteral nutrition could not be advanced more than 60%, even after a week. Then we can consider parenteral nutrition in addition to the enteral nutrition. There is a theoretical risk of lipid absorption onto the membrane oxygenator because of the lipophilic nature, but that doesn't prevent starting any lipids. So coming to physical therapy, there are some challenges for physical therapy patients the patients are on ECMO, because they're the sickest of the sick patients, and majority of the time they're either sedated heavily and paralyzed. And the top of that, there's a circuit attached, and you don't want anything to happen to the circuit. And many times, for our situations, either we staff to just enough or inadequate staffing, and our staff have not have enough training where we can leave it to them on their own. But there are a lot of studies are done looking at, is the physical therapy possible on patients on ECMO, and is it safe if it is possible? And all of them are shown physical therapy is feasible and safe in patients on ECMO. But one needs to prepare for how to do physical therapy meticulously. Sorry. So this is a pediatric patient who was on ECMO for ARDS. So we could prone her. Well, it's not, size doesn't matter. Even adults also we can do that. And that has been well recognized during the COVID pandemic. So then coming to maintaining a patient, awake patient on ECMO. So what does it mean? What it means is either initiating ECMO without intubation or ventilation, or extubating the patient while they're on ECMO. So you go on ECMO and the patient stabilizes, and then you extubate them. The reason is, once the lung function is bypassed by the ECMO circuit, we don't need to ventilate. And all the problems associated with ventilation and intubation, and consequently sedation. So we can avoid all those problems. So it seems to be good, but is it for everyone? We'll come to that. So if you have a awake patient, they can do physical therapy, and this is usually practiced in patients who are waiting for transplant, especially lung transplant. It's been shown that if they are on ECMO and they're not doing any physical therapy, the post-lung transplant mortality is going to be increased. So usually you wake them up and you do them physical therapy, and the transplant becomes available. Another thing is, common things, they're spontaneously breathing and they're looking at the gadgets, they're comfortable. But so it also provides some benefits of spontaneous breathing, where it optimizes ventilation perfusion mismatching and maintains the functional additional capacity, and associated all the problems with ventilator, like diaphragmatic dysfunction, VAP, all those things will be prevented. But the other side of spontaneous breathing, it's been shown that patients with ARDS, even though their CO2 levels are low on ECMO, they still be at having air hunger and they'll be breathing really vigorously. So in those patients, spontaneous breathing is not a good idea. So usually it's better to take control and maybe sedate and paralyze those patients, because just by spontaneous breathing and air hunger, they're going to increase the lung injury further. And sometimes the patient deteriorates on ECMO and not ventilated, then we might have to intubate an emergency basis, and which can cause some problems. Again, similarly, if you have awake patients, you can kind of avoid all the problems associated with sedation and reduction of delirium. We can do better rehabilitation. There's a better interaction with the staff and family, and everybody feels good. But this other side of the coin is one has to be really cooperative, not to pull out any lines. If the patient is not cooperative, then it's a risk actually you making them awake. And some patients, they're quite anxious and they won't be comfortable in new environment and pipes sticking into their body, and everybody's talking about whether they're going to make it or not. So what does ELSO say? There are certain ELSO has issued some guidelines. So what it says is you assess whether they're ready for endotracheal intubation. So first you look at the patient clinical condition. That means they don't have any other associated problems like severe shock or multi-organ failure, and patient is awake enough at least to protect his airway and cooperative enough not to cause significant harm or dislodgement of cannulas. And the secretions are manageable without any artificial airway. And if you come to gas exchange criteria, sorry, gas exchange criteria, they should be on minimal ventilatory settings, and they should have a good gas exchange. And they should not needing high PEEP, those sort of things, and there shouldn't be any ongoing congestive cardiac failure or morbid obesity. So if the patient fits this criteria, we can consider extubation. So this is kind of a middle path. We found it quite useful in our unit where we do, sorry. So we do early tracheostomy and the patient is cooperative enough, then we'll stop the sedation and wake them up. So it kind of helps us to avoid some of the problems associated with sedation and endotracheal intubation. At the same time, we can give full ventilation if the patient needs. So it's not only for adults, we can do it for children also. So even the small babies also, we can extubate them. Again, as I said, we need to choose our patient. So you need to choose the right patient who can actually benefit from that. Otherwise, the risk is going to be more. So coming to the end, ECMO is one of the most invasive modes of treatment, and whoever is dealing any patients on ECMO, they need to have some kind of emergency plan if something goes wrong, how to deal with it. So if something goes wrong, you should have clamps at the bedside where you separate the patient and the ECMO circuit. And one takes care of the patient, which means you start ventilation or go up on the ventilatory settings and then start inotropes or do CPR if whatever is needed for the patient. And another person deals with the circuit and make sure whatever the problem with the circuit, troubleshoot it as soon as possible, and the patient goes back on ECMO. But it's always have a certain kind of a plan at the bedside, what to do. And also call for help. So to conclude, so if you have a checklist kind of thing, starting from the moment you receive the call, pre-ECMO, on ECMO, how to do a safe ECMO, kind of a checklist where you go through each and every aspect of the ECMO care so that even one step is not missed, and at the same time document that and who is seen. So it kind of takes care of most of the aspects. And one needs to have a circuit knowledge and how to troubleshoot and how to have an emergency plan, whom to call for help. And care of the patient is like any critically ill patient, taking care of few aspects which are related to ECMO. And all the patients should get physiotherapy when the patient condition allows. And consider early enteral feeding as soon as possible. If the enteral feeding is not possible, either you can supplement with parenteral nutrition or give parenteral nutrition exclusively, depending on the clinical status. and consider waking up patients and extubating on ECMO, but in select patients where you think the benefit is going to be better. Then always have some emergency plan if something goes wrong. Thank you very much for your listening. I'm ready to take any questions. Thank you.